All right, looks like we've got most people in. Hello, good afternoon, good morning morning to Hawaii, afternoon to everybody else. Thank you for joining us this Wednesday for It's Worth a Shot. We have Jessie Kinsey from Pharmerica doing narcotic inventory management in nursing homes this week. Can we go ahead and go to the next slide? And as always, this presentation may contain information and or content supplied by third parties. This information provided does not constitute endorsement or recommendation by Mountain Pacific, but we like to have as many outside speakers and perspectives as possible. So that's why we bring you these things. Next slide, please. Okay, we have a couple reminders. We've got 2 slides worth, and all of these were actually provided to us by QI Times. I'm not sure if you guys sign up for that resource, but it's actually really nice. And we decided to pick some quality co-op resources. So these are from other Quinn QIOs across the country. So they've got an adult vaccine toolkit with the link provided. There's infection control and immunization practices in nursing homes with the link provided. As you can tell, these are all vaccine related. It's unfortunately about that time of year again. So then we have evolution of the COVID-19 vaccine, which is actually pretty interesting and educational, so you can find out the timeline and all that stuff. And then they also have some motivational badge buddies that can be printed out and added to your name clips or those things that go around your neck that I cannot remember the names of them right now. Lanyard. So we've got those. Let's go to the next slide. And this is actually a webinar that was conducted, and it might just be kind of interesting to look in on and see how Alliant was able to help a South Florida nursing home combat vaccine misinformation and brought up their immunization rates by more than 15%. So there's a link there as well where you can look at the blog series and find out, how that happened and what went on. Again, these will come out with the slides following the presentation. Next slide, please. And then again, we want to welcome you guys every Wednesday, and we appreciate the fact that you show up Wednesday after Wednesday with us. Mary will put a evaluation in the chat at some point, and we do appreciate if you fill those out and also give us topic ideas, because we have been running this for more than 2 years now on every Wednesday, and it can get tedious for us to not repeat topics. And so if you guys have ideas, we always welcome ideas or contacts for speakers that you think would be really great to present on this half hour. We'd appreciate that connection. Okay, we've got a polling question for you today. And again, this goes along the lines of immunizations. It's just kind of a check. True or false? Pneumonia vaccines are supposed to be given every 5 years. So do we know the answer to that? All right, got a pretty nice turnout there. Okay, Mary, let's go ahead and end the poll. And Kyla, our resident pharmacist, let's put you on the spot. And what is the correct answer?
Correct answer is false. Good job, everybody.
All right. Let's go ahead and go to the next slide, Mary. All right, I'm going to turn it over to Jessie. For some of you who have been with us for the long run, Jessie Kinsey is with Pharmerica, but she used to be with Mountain Pacific and actually was the first person to manage It's Worth a Shot when we were required to do this with just strictly vaccine information, and now we have branched out. So we want to welcome her back and give her the floor.
Thank you, Miranda. Thanks everyone for having me. It's good to be back, and I recognize a lot of familiar names coming through the feed from the waiting room. So thanks for having me. Next slide, please. So today I'm going to be talking about narcotic inventory management in our long-term care facilities, centers, specifically looking at kind of awareness over medication diversion and creating a little bit more of a discussion, an encouraging discussion about medication diversion in our long-term care facilities. ultimately, and those of you that know me, I feel like this is not a topic that we talk about enough proactively. We're typically, reacting to diversion situations. And there's a lot of things that we can do in a preventative measure to kind of uh, prevent ourselves from being in certain situations. And I think really, this is a very short time that we're together today, but we'll go over and highlight some key elements of medication diversion prevention awareness and kind of red flag warnings. So and we'll take a look at best practices too, and then we'll open up the floor towards the end of the presentation today for a little Q&A. So next slide, please. So diversion, as we talk about medication diversion, diversion occurs when a medication is redirected from its intended destination. And really, worldwide, we look at sedatives, pain medications, stimulants. Those are usually the common classes of drugs that are most commonly diverted, misused, or abused. And again, the opportunity today to discuss diversion and really maybe change the scene a little bit from reacting to more of a proactive approach is really the goal. And, we don't often report drug diversion like we should in long-term care settings. We go through, we react to it, we investigate it, but when we go back and look at reporting and we have studies out there, we really have room for improvement as far as quantifying um, and looking at drug diversion being reported appropriately. And drug diversion ultimately can result in felony charges. It is something that is um, uh, can result in criminal prosecution and loss of license. Next slide, please. When we look at prevalence of diversion, I was going to ask you guys, and I see a spelling error at the top of this slide too. Um, before the slide was advanced, I was going to see if anyone could guess the most commonly diverted medications. So oxycodone and hydrocodone, uh, that really consisted of just over half of diverted medications throughout the country. And let me ask a question, and you guys can throw it in chat. Does anyone know um, actually the number one diverted medication right now in the country? Any guesses? Feel free to throw that in chat. I'm curious to what your guess is. Okay. Any brave souls that want to, yeah, get morphine, fentanyl, tramadol, ADHD meds. Yeah. So on Adderall. Oh, hey, Sindra, she just hit it. Sindra, you are the winner. If I had a virtual prize to send you, I would send it your way right now. Ozempic, you guys, those GLP-1s, that is one of the most, and it's hit the top for diversion in our long-term care communities right now. And we'll talk a little bit more about that and how, yeah, unfortunately, we're going to have to update some processes on how we count Ozempic now. And we have many communities that are considering it like a controlled medication, and it's counted when received, counted when it's administered, and there's a little bit tighter control on it. So yeah, wow, Mandy, I'm with you. Ozempic. So nearly half of employees who stole medications, unfortunately, were nurses. Nearly 94% of diverted medications were opioids. However, just within the last 12 months, we have seen Ozempic and GLP-1s in general rise to the top of that list. The average duration of theft of medications, it has been occurring on average 56 days before it's identified and the individual is caught. 56 days, nearly 2 months, medication will be diverted before someone picks up on it. There's a thought to be a very strong connection between the lack of mental health support for healthcare providers in our long-term care settings, increased stress, staffing shortages, that are ultimately contributing to the prevalence of diversion. And, undoubtedly there's a ripple effect, right? Our patients. Next slide, please. Look at it, environmental contributors when we look at medication diversion. Prescribing habits, pharmacy deliveries. Um, where are those deliveries stored? Do your medication deliveries, sit in totes on the unit, on the floor for a while, maybe in a corner before someone gets to them? Or are you putting them away upon receipt? Discontinuation of medications. Again, how long are discontinued medications hanging around? When meds are DC'd, are you destroying them right away? How are you destroying them? Um, are you using maybe a RX Destroyer product or something similar where those medications are non-retrievable? Do you have more than one person that is destroying your medications? Ideally, it should not be designated to just one individual, or in some instances, controlled medications, two individuals. Is it always the same people or is it not? How's your documentation look? If documentation's a little sloppy, oftentimes that relates back to risk. Multiple prescriptions. So what I mean by this is if you're looking at a resident's profile and their orders, maybe they have a pain medication that's scheduled, and then they also have one that is as needed. Um, Oftentimes we look at those multiple prescriptions, multiple orders, and we'll identify increased risk for diversion as, do they need it scheduled and as needed, or do they just need to increase or adjust their schedules? Two different documentation areas, and if not everyone's looking at those areas, oftentimes we'll see where that's a good way to divert medications. Medication reconciliation. Kind of similar, just to make sure your orders make sense, and they're accurate to what that resident's diagnoses are. Um, and one thing that's not on here that is something that's, again, kind of moving up in the lineup, unfortunately, is there is a, and I'll say this again, unfortunately, there is a direct correlation between increased agency staff and medication diversion. And I'll tell you why and where the association has been identified is often we are putting that agency staff on a specific unit. Routinely, they're working just that specific unit. And we're not kind of intermingling our own core staff. So it's eliminating maybe a checks and balances that would naturally be there with core staff as far as medication reconciliation and documentation. So we also see too, and this is just a natural outcome, is when we're increasing our agency staff, it's because we're short staffed, right? We need the help. So we may be trying to balance our other routine audit needs. Maybe we're not doing those internal audits and process monitoring as frequently as we would if we were fully staffed. So again, there's a direct correlation to, when we look at medication diversion, increased agency staff, and unfortunately, that decrease in internal audits that would check some of these processes back into place and keep an eye on our medication counts a little bit closer. So that was a little long-winded, but I just wanted to highlight that's not something that's on this slide in front of us, but there is a correlation with agency staff. I would strongly encourage folks, if you are one of the many homes that's using agency, make sure that you balance that out with core staff if able, so that you have people coming through and keeping an eye on narcotic ledger books and documentation that know what it should look like. Next slide, please. So high cost medications, and that brings us back to Ozempic, right? So lifestyle specialty medications, they have really shot up as far as common medications being diverted. Those GLP-1s, Wegovy. Also, we look at Celebrex, Xanax, Seroquel, Zyprexa. Those all kind of filter out too when you start to quantify data of medications most commonly diverted. I'll say with these GLP-1s, again, we are seeing communities actively develop policies where they're counted like a controlled substance. Because what happens when this is diverted? Well, unfortunately, someone still needs the medication. Insurance isn't going to pay for this medication if it's a refill too soon. And pretty soon you start to see house charges going up for refill too soon. In Ozempic pens, you notice pretty fast when they hit the house charge. So that's the common way that people are actually catching diversion right now too, is for these medications, those GLP-1 specifically, is they're keeping an eye on those house bills, making sure meds aren't coming through refill too soon. Um, uh, Yeah, that's what I wanted to add. Kind of surprising, isn't it, to see these high cost meds or lifestyle meds hit that list. Next slide, please. So when we look at red flag warnings, and I kind of just highlighted and we'll zip through these, is when you have staff members that are insistent on caring for specific residents, just those residents, um, if you see frequent reports of maybe ineffective pain relief from some residents, maybe a PRN only being administered by one staff member, but then that resident denying receipt of medication, definitely a red flag warning. Your pain assessments aren't consistent. Maybe your MDS nurse goes out to do their quarterly and is completing him or hers assessment, but then looks on the chart and identifies some inconsistency. Maybe more frequent orders for a resident that really hasn't had a documented change in status. Again, all red flag warnings for potential diversion or risk. Next slide, please. Um, increase in narcotic record corrections. And we'll look at some examples in some ledger pages here shortly so you can kind of see what that looks like. Patients frequently report no relief at 1 to 2 hour rechecks. Again, just highlighting some of these red flag warnings. Sloppy charting, altered packaging, and we'll look at some examples of that. Next slide, please. So, large or unusual quantity requests, we've seen those uh, old school days when paper scripts would come through, you'd see numbers that you would question, and sure enough, there was reason to question them. Requests for refills on deceased residents. Still see some of this where a resident may discharge or is deceased, but a script comes through to the pharmacy the next day. Discrepancies with utilization of those ADU units, those automated dispensing units or e-kits. Another red flag warning is if those counts don't add up and maybe it's the same person that's been accessing the machine. Next slide, please. So again, this, I love these weekly webinars because this is just going to give you a taste and a high level overview of risk. And we're going to zip through here. So we're diving right into the kind of the images and examples that I wanted to show you to look out for. So when I say altered packaging, here is a perfect example, and you can see the tail end of it here in the image by number 22, where this medication was taped back in. If you're doing an audit on your medication cards, take a look at the back of the cards. See if you have a lot of medications that are taped back in. It used to be hydrocodone. Folks would tape in Tylenol. Um, I want to say I've seen aspirin taped in for Ativan. But again, medications should not be taped back into their packaging. If there was a reason that this was popped and then maybe the patient refused, then you would follow your proper waste and destruction policy in-house. I like to show that. Next slide, please. Here's another example if you're going through and auditing your ledger books. This is just a snapshot of your signature log page. If your signature log page looks something like this, you might have increased risk for diversion. So example, you'll look at line 20 there. And again, where all this red is highlighted. Those are times in which key exchange potentially or likely did occur, but there was no dual signatures. You cannot tell what time the keys were accepted by the next staff member and who co-signed, nor can you tell that a count occurred. So incomplete signatures, inconsistent counts, there's no dates, incomplete record keeping, all contribute to increased risk for medication diversion. And I'll say if you find yourself, in unfortunate situation, reacting to diversion and your documentation looks like this, it's pretty hard to go back and try to pinpoint the what, when, where, and how, and who. Um, Next slide, please. So another documentation example, again, just the circles here. If you have omissions in documentation, incomplete entries, maybe your counts don't add up, there's definitely a reason for further investigation, education, and follow-up. Next slide, please. Another example of poor documentation, and I'm laughing to myself, but I know it's not funny. If your documentation looks like this, I think that's my motto today. You're at increased risk for diversion. You can see all this documentation that's been crossed off. And if you, unfortunately in this image, you can't see the left-hand side, but this is documentation from multiple nurses, multiple days that one individual went through and crossed off and tried to self-adjust. So missing co-signatures for corrections, that's a big red flag. Quantities crossed off, improper use of ledger, all contributing risk. Next slide, please. So suspected diversion, internal investigation, really I like to put on here the first thing, you want to perform an internal audit of all your narcotic books. Notify your pharmacy, let them know what is going on. They can walk you through next steps. We can send you reports to help support auditing. And we can also deploy staff in Pharmerica's case to help conduct audits and help kind of look through the investigation. And one thing that is often overlooked if you suspect diversion is you really want to close those books out immediately. And the reason is those books, if you confirm diversion, they could be considered evidence in further investigation. Specifically, if other agencies get involved, including the DEA, those books you want to close out as soon as possible to prevent tampering or uh, uh, kind of loss of information or documentation in there. So notify your pharmacy, close those books out, and we'll help walk through the process with you. Next slide, please. So this, as Farm America, we put out a lot of tools, and I know other pharmacies do too, just to help respond to controlled drug diversion, what those steps look like, what immediate action needs to occur, who you need to contact, and then how to support plan of correction. And all this information will go out in the slide deck when Miranda sends it out. Notifying your pharmacy is again, let us know so that we can help. Okay. So next slide, please. And these slides I'll flip through pretty fast, so we have a couple minutes for Q&A. Big, as you look at reviewing your processes and prevention and reducing your risk, I remind everyone really best practice is to have a bound system for your individual narcotic record pages. Within that bound system, make sure the front of that book has complete documentation. When you open that book, the location of that book, some kind of identifier. Again, a bound system versus a loose leaf system. A loose leaf, you increase your risk, and we've seen it time and time again where folks will take the page, take the medication, and it could be a couple days before someone identifies that medication is missing. Bound system, it's numbered in a numerical order, so it's easier to identify if something is pulled out. Next slide, please. So controlled substance book, this is just an example from the PharMerica controlled substance ledger book. There's some nice example documentation as to what needs to be complete to reduce your risk. You know, when you sign your narcotics into a book, date, quantity, RX information, is it a transfer? Is this a new prescription? Is it from your, your dispensing unit? All that is very important information to have in there. If you're discharging someone, make sure you have that information completed. Next slide, please. Signature log page. This is often something identified in centers. They don't have a signature log page. Again, this is something that's extremely valuable if you're doing an investigation and an audit. Next slide, please. Shift audit record. Again, this is what you should be keeping an eye on doing routine audits. Make sure it's complete. And one thing that's added in here that you'll see is total quantity. What that means is you should also, it's a suggested best practice, count the items that you have in your cart alongside the individual narcotic count. So for example, you count everything page by page, but then if you have 2 cards and 2 bottles, you would put that you have a quantity of 4 items in that card, in that drawer. That helps with accountability too, as far as keeping track of, questioning each other if that count changes up or down. Next slide, please. Just an example of complete documentation. Again, it'll go out with the slide deck. And next slide, please. Common prevention strategies, a reminder, make sure anytime key exchange is occurring, you are signing and counting in your shift in your logbook. Utilize a bound system, do routine audits, and add in that item count. Next slide, please. In conclusion, ultimately we look at prevention, detection, and how to respond. Reach out to your pharmacy partners and involve them in conversations, ideally proactive conversations so that they can help you and help identify your risk. So we can actually bump down to questions. I see we're at the super tail end of this, so there's a few
Hey, Jesse, it looks like there's a couple comments in the chat. So Jessica said, one thing we have noticed is on the island is that no one does 2 signatures for discarding a fentanyl patch when removed. This is still considered a narcotic and should have 2 nurse signatures for removal from resident/patient.
Yeah, good catch, Jess. That is 100% correct. And often if you go to that center's or even pharmacy policy, depending on this community's who leads their pharmacy policies and procedures, you'll see that's in the policy and procedure, 2 signatures. And you should also have a patch placement check on your MAR. And that's a good checks and balances too.
We also
Okay.
have, is there a place on the island where we can send a family to get med bubble packs? That we might have to do a little bit more research into for Hawaii.
Oh yeah, yeah. We can probably look at some resources and I can share with you, Miranda. No problem.
Perfect.
Yeah, Mandy, bound system, man. I'll tell you, loose leaf is old school, and you go to a lot of these medication management, narcotic diversion, DEA education classes, and so much risk around loose leaf.
So I just have a quick question based on like one of the slides you had. You had the signature log, right? You know, where everybody signs in, have the initials, the signature, the nurses. Is there any instances ever where a nurse will, you know, get a copy of that, practice somebody else's signature initialing, and you know, force um, falsify, you know, somebody's signature for something?
You bet.
So then I
You
was
think
wondering, like, does it make sense then to have everybody's signature slash, you know, initials and whatever in the book, like, you know, for somebody to be able to actually look at and then copy? Or do you think somebody who's going to do that is just going to do that anyways, and there's really nothing you can do about it?
You
I
know,
mean,
that's
besides
such
the checks.
yeah, yeah, you know, that's such a good example. I have seen it done, and folks that are going to do that are going to do it anyway. They're going to find the signatures maybe in a nurse's note. They're going to find
Yeah.
the signatures in a treatment log. They're going to do it anyway. Yeah. Yeah. So really, you know, it's best practice. Review your ledger books. Make sure you have a signature log page in the front, especially if you have a lot of travelers coming and going. That's going to help you just in audit purposes and checks and balances. Yeah. Yeah.
Does anybody want to come off mute and ask Jesse any questions or have anything to say or share?
Why are travelers more at risk for diverting? Just curious.
Yeah. You know, from what my personal observation and some of the literature I've read is some folks that you know, they take traveling jobs that they know that they may already be diverting, and they know that they're not in a community long enough, and it's easier to get away with maybe diverting medications if you're not in a community very long. Day contracts specifically in some states, we've been able to actually trace it directly back to contracts in those circumstances. I'm not saying that's happening everywhere, but we're seeing where people that maybe more financially at risk have realized that, hey, if I'm with a travel agency and I bump around, it's harder for them to, you know, track me down, I guess you could say, if that makes sense.
Okay, anybody else? All right, well, we can go ahead and go to the last slide there, Mary. I want to thank everybody for joining us. Sorry we ran over a little bit here. This was a really good topic, obviously. And if you would want to hear more from Jesse on this topic or more in depth on something, definitely fill out the evaluation that is in the chat right now and let us know. And we'll see if we can strong arm her to come back at our discretion.
Yeah.
So next week we have August 21st, we're going to have combating stigma for opioids. Kyla will be presenting that next Wednesday. So just want to thank Jesse very much for coming back. That was a very stimulating, I don't know, can't think of another word for it, presentation. Really appreciated it. And thank you everybody for joining us today. And we hope to see you next week.
Yeah. Thanks, everyone. Thanks for having me. And Miranda, reach out if I can be of any assistance. And
Oh, I'll
uh,
volunteer you. Don't worry about it.
yeah, yeah, yeah. High level overview, but you know, maybe that intrigues others to open up the discussion. So thanks again.
Thank you.